I don't know all those details actually.
Who was your
Evening.
last
The last number was 250, and I should start 251 today.
All right, that's fine. So let me just thank you.
Please let me also request that I may need to leave. I have an exam I'm writing in 2 days' time, so we'll have to just do some touches.
Chief, we understand. We are most grateful. All these are for us. I'll see you help you on us and more concerned about how we get this discussion done this evening. We are very grateful.
So I think we have 60 persons or
Chief Okopi too called. Dr. Okopi too called. Called, yes, called him. We are grateful. We appreciate everyone, Chief. Thank you so much.
It's okay. It's all right. So we have up to 40 persons. I think I'm just trying to suggest that you guys need to organize it among yourselves. I will have stayed very well, but I need to just log out. I will be recording, but I'm not going to be active. That's what I mean.
Yes, we understand, sir. Thank you so much. We are grateful.
Thank you, Chief.
Thank you, sir.
Thank you.
Okay. Can I go ahead?
Yes, you can. Sorry, who's speaking? Let me look. Onyinye, Dr. Onyinye. Okay. Thank you. Yes, thank you so much. All right. Thank you.
Okay.
Thanks for the time.
So question number. Okay. Thank you. I'll start from question number 251. Which of the following statements regarding high-dose statin therapy is not correct? A. High-dose simvastatin results in a greater degree of skeletal myopathy compared with low-dose therapy, that is 20 milligram per day. This option here is a correct option because it says that myopathy is directly related to the dose and the type of statin that is used. So a simvastatin dose of 80 milligram, a simvastatin dose, like a high dose of simvastatin, for example, 80 milligram, is associated with an increased risk of myopathy compared with when you give lower doses. So option A is correct. So that is not true. That is not the right answer because the question says which of these concerning high dose statin therapy is not correct. Option B, high dose atorvastatin results in measurable regression of atherosclerotic coronary stenosis. This option is also a true statement because it says that high dose statins, especially atorvastatin, causes a reduction in risk of atherosclerotic coronary vascular disease. And it's classified amongst high intensity statins. So this statement is a true statement, which is not correct. Option C, high dose simvastatin, 40 to 80 milligrams daily, has been shown to reduce coronary events after an acute coronary syndrome compared with less intensive therapy. This statement is not correct because when I searched, it says that there was a trial that was done called the A to Z TIMI-21 trial. In these patients, they used patients who had acute coronary syndrome, and they were randomized and given they were divided into different groups. So some were given simvastatin 40 milligrams daily, while another group of people were given high dose simvastatin 80 milligrams daily. And it was noted that there was no difference at the end in any of these patients. So that means that the incidence of major cardiovascular events does not have any effect, whether you're giving a high dose simvastatin or a lower dose simvastatin. So option C is not correct. D option says, compared with less intensive statin therapy, high dose atorvastatin reduces subsequent mortality in patients after an acute coronary syndrome. This option is a true statement in a similar trial like the first one I had talked about, but this one is called the Prove It TIMI-22 trial. It showed that with high dose atorvastatin at 80 milligrams per day, that acute coronary syndrome was reduced significantly and the risk of death in people who had had an acute coronary syndrome. So for question 251, the not correct statement is option C. So the floor is open for questions and clarifications or more addition. Can I go ahead? Question 252. Which of the following statements regarding oral antiplatelet agents is correct? A. Aspirin's principal antiplatelet action is via inhibition of the PAR1 thrombin receptor. This statement is false. Aspirin is known to acetylate platelet COX-1, that is cyclooxygenase 1, by blocking the synthesis and release of thromboxane. PAR1 thrombin receptor antagonist is the oral antiplatelet agent that acts there is called Vorapasa. So option A is wrong. Option B, clopidogrel and prasugrel are irreversible inhibitors of the platelet P2Y12 adenosine diphosphate receptor. This is true. They inhibit ADP-induced platelet aggregation by irreversibly blocking the P2Y12. Option C, prasugrel displays a lower onset of action than clopidogrel. This option is false. Prasugrel is known to act more rapidly than clopidogrel, and it also produces a greater and more predictable inhibition of the P2Y12 ADP receptor. So option C is not correct. D, non-steroidal anti-inflammatory drug such as ibuprofen enhance antiplatelet effect of aspirin. This is false because it's known that this is false. NSAIDs are known to prevent the acetylation of COX by aspirin. So they do not enhance any effect of aspirin, rather they inhibit the effect of aspirin on COX. Option E, Silostazole's mechanism of action is by activation of nitric oxide synthesis. This is false. Silostazole is a potent inhibitor of phosphodiesterase 3 and it has vasodilatory properties. So the correct answer in question 252 is B. The one that says that clopidogrel and prasugrel are irreversible inhibitors of platelet P2Y12 ADP receptor. Any questions, any clarifications? Sorry. Question 253. Which of the following statements regarding pharmacologic inhibition of the renin-angiotensin system in patients with ST segment elevation myocardial infarction STEMI is correct? A, administration of an oral angiotensin converting enzyme ACE inhibitor for 4 to 6 weeks after STEMI reduces mortality only in patients with left ventricular ejection fraction of less than 40%. This is false. Administration of an ACEI inhibitor actually reduces mortality in all patients who have STEMI, but not in patients who have ejection fraction of less than 40%. So this statement is not correct. B, in patients with STEMI, the left ventricular dysfunction. In patients with STEMI and left ventricular dysfunction, an angiotensin receptor blocker in combination with an ACE inhibitor results in better cardiovascular outcome than an ACE inhibitor alone. This statement is false. It's known that in the Valiant trial, where an ACEI and an ARB was used, the combination of both did not offer any advantage to using either the drug alone, using either an ACEI or an ARB alone. However, it was found out that whichever one that was used gave similar clinical outcome. So in patients who are intolerant to ACEI inhibitors, an ARB can be used as an adequate substitute. But using both of them in combination doesn't give any better cardiovascular outcome than using an ACE inhibitor alone. So this statement is not correct. Option C, the mortality benefit of ACE inhibitor in STEMI commences 30 days after initiation of therapy.
Hello, Dr. Nye. We can no longer hear you. I think our network. Maybe we should wait. Try and give her some time.
Hello.
Hello.
Sorry.
Oh, you are back. Okay.
Hello, can anyone hear me?
We can hear you now. We can hear you now. We can hear you now.
Hello?
We lost you before, but we can hear you now.
We can hear you now.
Okay. Sorry, please. My network at home is very bad. Okay.
It was okay until now, actually. Hold on.
Okay. Thank you very much. Okay, so I was in question 253, option C. The mortality benefit of ACE inhibitors in STEMI commences 30 days after initiation of therapy. So this statement is false. It's known that the mortality benefit of ACEIs actually starts within the first 2 days of commencing an ACE inhibitor. So it's not 30 days after initiation, but rather 2 to 3 days, the first 2 days after initiation. Option D, oral administration of the selective aldosterone inhibitor eplerenone is associated with reduced mortality in patients with STEMI and left ventricular dysfunction. This option is correct. It's known that during the Ephesus trials that the role of aldosterone inhibitor eplerenone was used, and it's resulted in about 15% reduction in mortality compared with people who were treated without the selective aldosterone inhibitor. So for question 253, the correct statement here is option D. Can I go ahead? Question 254. A 42-year-old man with a long smoking history presents with claudication and rest pain of his right calf and foot.
I wanted to use back. I wanted to turn and use front and enter. Okay. As this one is.
Presents with claudication and rest pain of his right calf and foot. An angiogram of his posterior tibial artery is shown in figure 2.8. Sorry, please, could you help? Thank you. So so this is figure 2.8. If we look well in this figure, we'll actually see an angiogram that is shown. There is one shown on the left side and on the right side. The one on our right shows is an angiogram. If you trace it from up, we'll see the popliteal artery coming down. It gives up the anterior tibial artery, continues down as the posterior tibial, and still gives off another artery, the peroneal branch. The arrow is, however, pointing at the anterior tibial and the peroneal arteries, the right. So it shows an occlusion there where we can't see. Okay, yes, thank you very much. So this angiogram shows the occlusion of the anterior tibial and the peroneal artery. However, on the other diagram, it shows some tiny vessels below the occlusion of the posterior tibial artery. This is known as collaterals. These are collaterals that have formed to help supply blood around the area that has an occlusion. This is known as the corkscrew collaterals. So looking at this angiogram, it shows that the occlusion are actually not in the major arteries, but in the small-sized and medium-sized arteries. So the diagnosis here for this patient is thromboangiitis obliterans. Now, to make a diagnosis of this, with the history that we've had, the history, most times we actually look out for the age of the patients. It said that the patients that have this actually young people, mostly 25 years to 45 years of age. It's actually commoner in men. And most times in the history, we'll get a positive history that these patients are either in current use or even if they stopped tobacco use, but a recent onset of stopping the history and the use of tobacco. Thromboangiitis obliterans is an inflammatory vasculopathy, and it is characterized by inflammatory endarteritis. So in the option said, which of the following statements about this condition is correct? A, it affects primarily the large vessels of the arms and the legs. This is not a true statement because I said that this disease is characteristically known to affect small and medium-sized arteries as well as veins of the upper and lower extremities. Option B, high-dose statins therapy improve the symptoms in these patients. This option is false. There is no role of statin in treatment of this patient. So whether you give them high dose or low dose statins, it has no effect in the symptoms of this patient. C, smoking cessation improves clinical outcome. This is true because in treatment of these patients, the primary thing to do for them is cessation of tobacco use. So option C is correct. Vascular surgery is usually required emergently. This is false because, however, they said vascular surgeries actually are not an option in the treatment of these patients because it actually occurs in medium-sized vessels and usually in the medium-sized and small vessels. So really, there's really no role for vascular surgery here. More than 75% of the patients with this condition are women. This is not true in the epidemiology for these patients. Rather, more than 75% of these patients are commonly men. Any clarifications or questions before I move to the next? So question 255.
Yes, please, ma'am. I just wonder, what is actually the treatment for thromboangiitis obliterans?
Sorry, I didn't get you. Sorry, please.
I said, so they don't do any vascular
Hello,
interventions. Sir. Can you hear me? Can you hear me?
Yes, I can hear you now. Okay. Yes, I can hear you, sir.
So
I can hear you.
So, okay, I said, so how do we treat thromboangiitis obliterans?
Okay, for the treatment, sir, it says that most important is cessation of tobacco use, then Also, most times when they are exposed to cold, it triggers the symptoms. So it's important to avoid things that could trigger this patient's symptoms. Also, most times it's noted that because of the reduced blood supply, they actually present most times with vascular ulcers. They usually have ulcers in the lower limbs. So it's important they have ischemic ulcers, gangrene. So it's important for these patients good skin hygiene. There is no definitive treatment, but it's noted that in some patients, the use of hyperbaric oxygen has been used, and it is said that it had improved healing of the ulcers this patient had, and also reduced the possibilities of having amputation. That's use of hyperbaric oxygen. Also, I saw they said busentan can be used, but in refractory cases, in people who the ulcers are not healing. Also, I saw that they could use IV prostacyclin analogs. An example they gave was again. I'm not very sure. I think I saw Island. I'm not very sure again, but I read that there was no role for vascular surgeries in these patients. The floor is open for more contributions.
Okay,
please.
That was helpful. Thank you, ma'am.
Okay, sir. Question 255. Which of the following characteristics is typical of hypertensive crisis? Okay, we all know what's hypertensive crisis. So there is hypertensive emergency, and there is also hypertensive urgencies. So for hypertensive emergency, it is when there is elevated blood pressure levels. Some say there is no specific diagnostic blood pressure level, while some text said when you have a systolic of more than or equal to 180 millimeter of mercury and a diastolic blood pressure of more than or equal to 120 millimeter of mercury, and the presence of acute ongoing target organ damage, that tells you that the patient has a hypertensive emergency. While in urgency, it's the same thing, but however, there is no ongoing target organ damage. So in the options, it said, which of the following characteristics is typical of a hypertensive crisis? A, central retinal artery occlusion. This is not true. In hypertensive crisis, what you rather see when you do a retinal examination, you see acute hemorrhage, exudations, and papilledema, not central retinal artery occlusion. For B, constriction of cerebral arterioles with decreased vascular permeability. This is also not true. In hypertensive encephalopathy, rather, there is failure of cerebral autoregulation, and there is dilatation of the cerebral arterioles leading to excessive cerebral blood flow. So we don't have constriction of the arterioles, rather we have dilatation. C, renal insufficiency without proteinuria. This is also not correct. In hypertensive crisis, we have renal insufficiency with proteinuria and not without proteinuria. And then D, microangiopathic hemolytic anemia. This is correct. Severe hypertensive crisis is a cause of microangiopathic hemolytic anemia. He said this causes it by when there is the increase in blood pressure leads to disruption of vascular endothelium, and there is release of fibrinoid materials that are released into the vascular wall, and they can cause occlusion of the vascular lumen. So microangiopathic hemolytic anemia is a common finding in patients who have hypertensive crisis. Any questions or clarification or contribution to the question, please?
Hello. Hello.
Yes, ma'am.
Okay, sorry, I'm trying
to take
you back to I'm trying to take you back to question number 254 because I was trying to speak with you, but I think I had an issue with my network then. Okay, so as regards this thromboangiitis obliterans, that's is it Buerger's disease, whatever they call it. So we are trying to say that
yes, ma'am.
In taking the diagnosis of thromboangiitis obliterans, it means that other risk factors of atherosclerosis will be ruled out. Like, is a diagnosis of exclusion just only seen in smokers? That's what it means, right? Because you're saying that cessation of smoking. Okay, so it's actually seen in smokers.
Yes, exactly.
Who do not have any other atherosclerotic risk factor. Okay, because what I'm seeing
they do not
here,
have atherosclerotic risk factor.
Okay, so just in smokers. So just in smokers, we see it in smokers alone.
Yes, it's seen majorly in smokers, and he said most times that what you actually should rule out is not even the peripheral artery disease. What you should be worried about is all them, because this actually comes in. It comes usually. He said it comes with symptoms most times that actually look like autoimmune diseases. So you actually should exclude other autoimmune diseases. For example, this patient they actually have Raynaud's phenomenon. They have cold. They have once there is cold, they have pains in the tip of their fingers, lower limbs. They have. It was explained more. Like
no
I'm
problem.
trying to find.
No problem. Thank you. It's understood. Thank you so much. Thank you.
Thank you very much, ma. Okay, you're welcome. Question 256. Which of the following conditions has not been associated with the abnormality demonstrated in the transesophageal echocardiogram image in figure 2.9? Okay. Thank you. This is the image. I don't know if there's anybody who could help describe this image. I tried to look it up in the answer and I saw that they said this was an image transesophageal showing an aortic dissection, but I didn't know I didn't understand the picture. I didn't know what each one meant. So I don't know if there's anybody here that could help us, please. Thank you.
Thank you, Dr. Oye. Let me just maybe an attempt. When we see images like this and we see this semicircle where my cursor is, it gives it out that is a transesophageal, even if you are not conversant with the different views. You understand? And this view is likely to be a medium esophageal view. And this, where my cursor is actually the aortic roots. This is the aortic valve, as you can see. Can you appreciate it? This is the left side of the heart.
Yes.
This is LA. That's the left atrium. You understand? And extending like this. You understand? And this is the aortic valve, and this will be the left ventricle. Did you get that? So
yes,
this
yes.
is the aortic roots. So in these aortic roots, you can see it appears a little dilated. I don't know what the question is. Sorry, I've not gone through it. So maybe they are going to give us diameter, but to me, this appears dilated. So this we are seeing is the left ventricular outflow tract, although we can't see the upper border here, but this is the left ventricular outflow tract. This is the aortic opening, and these are the cups, as we call it, opening of the aortic valve. Then after that, we expect to see this imaginary line I'm drawing. That's the sinus of Valsalva. That's where we have the insertion of the aortic cups at this level. So those are the things we look at. After the sinus of Valsalva, we are supposed to have the junction. We call it this is a junction now. I'm trying to remember. That's the junction between the aortic valve and the aortic roots. Sinotubular. Thank you. So that's the sinotubular junction. Ideally, we should see it thinner, appears narrower. That's the word. Than the corpse, but it appears at this that there is a pathology here. So that's why we are not really seeing a clear demarcation. Then after that is the ascending aorta. So in this ascending aorta, you can see this echogenic structure. You can see. Can you see where my cursor is? Do you understand? Can you?
Yes, I can see it. Yes,
Okay,
ma'am.
yeah. So that's the flap.
Yes.
That's the dissecting flap. So this where my cursor is should be the false lumen, labeled F. It's supposed to be the false lumen now, and this is the actual lumen. Do you get that?
Yes, I can understand you. Thank you.
All right. Thank you.
Okay. Which of the following conditions has not been associated with the abnormality demonstrated in the transesophageal echocardiogram image in figure 2.9? So thank you for the explanation, Ma. The first question says, A is heroin use, B is hypertension, C is Marfan syndrome, D is bicuspid aortic valve, and E is pregnancy. So it's asking which of these conditions is not associated with the abnormality demonstrated as, which of this is not associated with the aortic dissection. So A, B, let me just go to the answers. Okay. So A, heroin use is the answer because it says that cocaine has been associated with aortic dissection, but there's not been any recorded association with heroin to aortic dissection. B, hypertension. Hypertension, the major predisposing factor for aortic dissection is cystic medial degeneration. Of the conditions that promote cystic medial degeneration include age, hypertension, and they are said to be the two most common causes of aortic dissection. Hereditary abnormalities of connective tissues have also been implicated. Examples, Marfan syndrome, Ehlers-Danlos syndrome. Approximately half of all dissections in women younger than 40 years occur in association with pregnancy, most commonly seen in the third trimester or in the early postpartum period. Cocaine, but not heroin, has been associated with aortic dissection. So this is the answer I just read out. So in the options, the answer is A. So hypertension, Marfan syndrome, bicuspid aortic valve, and pregnancy has been implicated in causing aortic dissection, but heroin use has not been implicated. Question 257. A 76-year-old woman is assessed in the office 3 months following an anterior ST segment elevation myocardial infarction. Patient was treated with drug-eluting stenting of the proximal left anterior descending coronary artery. Of the left anterior descending coronary artery percutaneous coronary intervention. The post-procedure left ventricular ejection fraction was 50%. The patient completed cardiac rehabilitation and has made beneficial modifications to her diet as a result. She quit smoking at the time of her STEMI. Current medications are aspirin 81 milligrams daily, prasugrel 10 milligrams daily, metoprolol 50 milligrams daily, atorvastatin 80 milligrams daily, and ezetimibe 10 milligrams daily. Her blood pressure is 124/78 millimeter of mercury. The low density lipoprotein cholesterol level is 105 milligram per dl. Which of the following options will be the next step in this patient's lipid management. So that means this patient, like the important things to note out is 76 years, had STEMI 3 months ago, has quit smoking, ejection fraction is 50%, on aspirin and prasugrel, so it's on double antiplatelet therapy, on metoprolol, also on atorvastatin 80 milligrams daily, and ezetimibe of 10 milligrams daily, and still has an elevated LDL cholesterol of 105 milligrams per dl. So the options are A, no changes are needed in the medical treatment of this patient. So this is not a correct statement. The patient had a STEMI 3 months ago, currently receiving atorvastatin 80 milligrams and also ezetimibe 10 milligrams. So this patient, despite the fact she's on high intensity statin and also on a cholesterol absorption inhibitor, she still has elevated LDL. So she actually needs some changes in her medical regimen, because this LDL that is high still makes her at risk of having another coronary event. B, start evolocumab 140 milligrams subcutaneously every 2 weeks. Let me just read all the options. Option C, increase ezetimibe to 20 milligrams daily. D, decrease atorvastatin to 40 milligrams daily because of the patient's age. So option B, evolocumab. What is evolocumab? Evolocumab is actually a lipid lowering agent. It's noted to act on pro-protein convertase subtilisin kexin type 9. Sorry, it's just called PCSK9 inhibitor. So it's a lipid lowering agent, and it said that for this patient who is on 2 anti-lipid medications and still has elevated LDL, there is a guideline. It's actually a US guideline. It recommends that for patients who has had the recent acute coronary syndrome, LDL targets for the patients are usually less than 70 milligrams per dl. So if these patients are actually already on 2 lipid medications, that is including a high intensity statin like atorvastatin 80 milligrams, and also on a second medication for this patient, the patient is already on a cholesterol absorption inhibitor, that is the ezetimibe at 10 milligrams daily, it's advised that these patients, you can commence the PCSK9 inhibition for the patients. And this is evolocumab. Is usually given as 140 milligrams subcutaneously every 2 weeks. Option C said that the dose of ezetimibe should be increased to 20 milligrams daily. This is not correct, because for the dosing of ezetimibe is known to be given at 10 milligrams once daily. So there is no benefit in giving the patient an increased dose or a high dose that is not recommended. Option D says that you should decrease atorvastatin to 40 milligrams daily because of the patient's age. This is not a correct statement, because there is no rule for reducing statin based on patient's age. Rather, most times you could reduce statin if patient has complications from the medication, like if patient has side effects of myopathy, it's a reason to reduce the medication, but not to reduce it based on the patient's age. The floor is open for contributions and questions, please.
So, ma, please, which one is the answer, ma?
Okay, the answer here, sir, is option B. Start evolocumab 140 milligrams subcutaneously every 2 weeks.
All right, thank you, ma.
So why is there any particular reason why evolocumab is able to further decrease and statins, high-intensity statins are unable to do that. Is there any significant difference in the mechanism of action?
Okay, it says that the evolocumab, that's the PCSK9 inhibition says that it actually acts on LDL cholesterol specifically. So when I read about it, it said that the important thing is that the patient should have their risk of having another ACS low. So the ideal thing is to actually add an extra medication to make these patients, to adjust their LDL. So they said that this PCSK9 inhibitors actually acts on low density lipoprotein. So because it acts specifically on that and reduces it significantly, that I should add it. I didn't see any other reason, sir.
Well, just like I said, I also want to thank Chief Ajayi that if we look at these options very well, already we know these are patient needs high intensity statin. It's already on 80 atorvastatin, which is the highest dose that we can give at this instance. So decreasing it to 40 is a no-no. We know that. No changes are needed. That's a no-no because our target is 70, like she has said. If you look at increase as a Assessemt, she has already said the highest dose is 10. And we are looking target here is our LDL. So which other, the best option that best suits here would be just to look for ways to reduce this LDL cholesterol to targets because the patient is still far from target. And the only thing that will help us achieve that is B. That's an angle to hit, actually.
Well, no, thank you. Thank you.
Okay, I thought you were asking for the mechanism of action.
Yes, okay.
I think he was asking for mechanism of action, Dr. Ajayi, am I right?
Yes, it was one of the questions. Yes, that is true. I was asking about the mechanism of action also because we could also come across questions that may test our, our knowledge based on what the mechanism of action is. I think the PCSK9 itself binds to LDL receptors and degrade them. But when we now use the PCSK9 inhibitors, you prevent the binding of PCSK9 that causes the degradation. So it's just like you give a lifeline for those LDL receptors to live, and it results in the further metabolism and lowering of the LDL stores. In contrast to the statins that we know they block the rate-limiting step in the metabolism of hydroxymethylglutaric coenzyme A, converting them to mevalonic acid. So, Abi, I think that's the.
Yes, you are right,
yes,
Chief. And they are also excreted via the liver. That's hepatic cells. So, in cases of maybe when we have liver pathology, is not a good alternative, which these patients don't have. Then it's not that maybe patient is reacting to statin, you now already have maybe a hepatic problem, you now want to switch to it, it will be no. So there are indications, and just as you have said, but is also targeting the bad cholesterol, which is the LDL. Thank you.
Thank you.
Okay, and to further add to the mechanism of action, there's another class of drug that is the small interfering the small interfering RNA therapy. That's where inclisiran comes in. So the difference between inclisiran and this other one, the evolocumab, is that while evolocumab are inhibitors of PCSK9, the inclisiran, what they do is that they go to the molecular level. So they try to stop expression of PCSK9 so that it will not even be expressed. Talk more of trying to suppress expression of these hepatic receptors. Thank you.
Thank you very much.
If I might just add, of course, like we keep saying, cardiology is obsessed with outcomes, so prevention of stroke, MI, mortality, and morbidity. So of the antilipids, I mean, fibrates are not particularly popular, partly because what they mainly do is reduce TG, but also because they've not been shown to really improve mortality or morbidity. So of course, statins we know are really good with all their benefits and pleiotropic effects and all of that. They're oral. Ezetimibe works by inhibiting absorption of cholesterol from the intestine. So it acts at the intestinal brush border. Then, of course, a step ahead is the PCSK9 inhibitors. Apart from evolocumab, there's alirocumab. I don't know why the names sound like tongue twisters. But there's evolocumab, there's alirocumab, and they're only injectable, i.e. there's no oral preparation, and they're given every couple of weeks or every couple of months. I think there's a loading dose, and then subsequently the duration, the interval is made wider. And of course, then there's inclisiran that you mentioned. So the PCSK9 inhibitors have also been shown to improve cardiovascular outcomes, in addition to lowering LDL cholesterol through the mechanisms already mentioned. Thank you.
Yeah, thank you, Dr. Rukaya. Also, what I know for this, the evolocumab, I think I know it as you give a loading dose, the subcut, then I think, is it after 3 months, another one, then you start giving 3 monthly. So this every 2 weeks, I don't think I've ever come across it. I don't know.
Okay. I think that's for alirocumab. I wasn't sure. I just meant there's a loading dose and then there's some interval subsequently. I think the 2 weeks may be for alirocumab. I'm not sure. Please go and check. But the bottom line is they're both injectable. Are they given repeated after certain durations? Thank you.
Okay, thanks.
Okay, thank you very much. For the dosage, when I checked the text, it actually says that how it's given. It's actually giving 140 milligram every 2 weeks or 420 milligram once monthly. Then for the inclisiran, is giving 300 milligram twice yearly. While there's actually a third one that is among the PCSK9 inhibitors, that's the alirocumab. It's given at 75 milligram every 2 weeks or 300 milligram once monthly.
Okay, thank you. So I think it's the higher dose that is the monthly spacing. Thank you.
Hello, sorry, seems I went off again. Sorry for the network wahalas. Can I go ahead? Can anyone hear me?
We can hear you.
Yes, we can hear you. You can go ahead.
Okay, thank you. So question 258. Which statement about the diagnosis and treatment of right ventricular infarction is not correct? Question A. Option A, sorry. Hypotension in response to small doses of nitroglycerin in patients with inferior infarction suggests right ventricular infarction. This is true. In right ventricular infarction, usually it says it has some recognized characteristic clinical and hemodynamic patterns. And amongst them, they have hypotension or marked hypotensive response to nitroglycerin, or also to diuretics in patients who have right ventricular infarction. So option A is correct. Option B, unexplained systemic hypoxemia in right ventricular infarction raises the possibility of a patent foramen or valley. This is also correct. It says that in patients who have right ventricular infarction, the presence of unexplained hypoxemia actually suggests the possibility that there is a rise to left shunt in this patient, and most times the commonest cause in this patient would have been a patent foramen or valley accepting a right to left shunting of blood. Option C, hemodynamic parameters in right ventricular infarction often resemble those of patients with pericardial disease. This is also correct. It says that in patients who have right ventricular infarction, they usually have similar hemodynamic features like patients who have pericardial disease. They actually have they have increased right-sided filling pressures. They're elevated. There's right atrium, right ventricular end diastolic pressures are increased. And in this patient, most times, the common signs that are seen in right ventricular infarction that can also be seen in the pericardial disease include a positive Cosmol sign, that's a paradoxical rise in right atrial in JVP during inspiration. You could also see elevated right ventricular filling pressure. There are also other ones listed. D, loop diuretics are usually the preferred initial therapy for patients with right ventricular infarction and intact left ventricular contractile function. This option is false. In patients who have right ventricular infarction, they have reduced left ventricular preload. As a result, for these patients, actually, if you give diuretics, you actually worsen the patient's symptom. They actually have profound hypotension. He said that patients who have right ventricular infarction, the important first step you should actually take care of is, because of the possibility of hypotension, you should actually give them volume expansion. IV fluids should be given rather than diuretics that could worsen the hypotension they could have. Option E, ST segment elevation in lead V4R is a sensitive and specific sign of right ventricular infarction. This is also correct because in patients who you're suspecting to have right ventricular infarction, placement of right-sided precordial ECG leads can actually be a pointer where you see ST segment elevation in V4R, and is said to be specific and very sensitive for this patient. So in question 258, the option that is not correct is actually D, that loop diuretics are preferred initial therapy. Please, contributions and questions.
Please, I have a question. That's option B.
Okay,
is it that it's the right ventricular infarction that caused the patent foramen overall? I'm just asking.
No, the right ventricular infarction actually is not what caused the patent foramen or valley, no. But if you have a patient and you have confirmed that the patient has a right ventricular infarction, ideally, these patients are not expected to have, systemic hypoxemia is not a common finding in patients who have right ventricular infarction. But if you've confirmed that a patient has right ventricular infarction, for example, you have an ST segment elevation in lead V4R, and you now notice that the patient also has systemic hypoxemia, it is a pointer and it raises a suspicion that the patient might have a patent foramen or valley. Not that in every patient that has RVI, it causes patent foramen or valley. No, ma.
Thank you. I get it now. Thank you.
Okay, ma. Can I go to the next question? Question 259. A 65-year-old man presents with several months of right lower extremity discomfort and fatigue while walking. Segmental pressure measurements were obtained as shown in figure 2.10. Which of the following statements is true? Please, can we see 2.10? Okay, thank you. In 2.10, this is a picture showing us the measurement of the ankle brachial index for this patient. If we look at the measurements, we actually see that if we look at the picture, we actually see that there are segmental pressure cuffs that are placed on different parts of the lower limbs. It's actually placed in the upper thigh, lower thigh, the calf, the ankle, and also above the metatarsal area of the foot. And the systolic pressure are usually measured using a Doppler probe. If we look at the up parts, we'll see where they wrote the brachial pressures for us. So the left brachial pressure is 127, while the right brachial pressure is 132. Also, if we look downwards, we'll also see the pressures down. We'll also see the pressures from the common iliac going down to the popliteal, the posterior tibialis, the dorsalis pedis. Okay. Can we get to the question, please? A, an ankle brachial index greater than 0.85 is considered normal. This is not correct. In ankle brachial index, actually, there is measurement of the cuff pressure where you check for the brachial and you check for the ankle, and you do the ankle value over the brachial value. The normal ankle brachial index is when you have it greater than 1.0. So when they said the ankle brachial index greater than 0.85 is considered normal, this statement is a false statement. Question B, the pressure difference of greater than 20 millimeter of mercury between successive cuffs is evident of significant arterial stenosis. This is also true. This is a true statement because a pressure gradient that is greater than 20 millimeter between successive cuffs is significant of stenosis, but this is when it is in the lower limbs. For the upper limbs, 10 millimeter of mercury is said to be significant. So option B is true. For option C, critical limb ischemia is associated with an ankle brachial index of 0.8 or less. This statement is not correct. Critical limb ischemia is said to occur when the ankle brachial index is less than 0.5. Option D, the sensitivity of the ankle brachial index for the diagnosis of peripheral artery disease is increased in severely calcified arteries. This is false because it's noted that if arteries are heavily calcified, they will be incompressible. So that is in these patients. Okay. So that means in these patients, such vessels will not compress. So most times you actually have high systolic pressure readings. So this makes this option D false. Option E, the patient's main abnormality is the right tibial artery stenosis. If we go back to that picture, this option E is false because if you look at that picture on the right side, the pressures were reduced right from the femoral artery, popliteal artery, down to the posterior tibial, down to the tibial artery. So the stenosis is not just, okay, thank you very much. if you look at this picture, while on the other, from up above around the femoral, we start getting 96, 77, which were low. So that tells us the option there says that the problem is at the tibial artery. But before it got to the tibial artery, the pressures were already low. So that tells you that the problem is not from the tibial artery, rather it's high up. So it's right from the iliac and femoral arteries and not the tibial artery. Thank you very much. While I was talking, I saw a message in the box that says that critical limb ischemia is 0.3. I'm sorry, when I was reading the text, I actually saw 0.5. So I don't know which one is correct. Please, I need help.
It's less than 0.5.
Yes, it's 0.5 that me I've seen in most books. So although in some other materials I've seen them quote 0.4, 0.3, but from Harrison to Braunwald, what I've majorly seen is less 5. But what me I don't even understand is this this picture, this graph-like things on the extreme, on my extreme left of the screen. You know, I was trying to make sense of it because I know that from the explanations that have been given, a pressure differential of more than 20 millimeter mercury translates into significant, stenosis. So when I know that greater than 46, okay, this is millimeter. Nothing pressure. That is. Thank you, Jare. At least I've stopped confusing
We're talking
myself.
about is the amplitude that we are looking at. If you compare the amplitude on the right to the left, that's what they are trying to show. So the pressure waves, the amplitude decline or is not as tall, even at the same level.
On the right, they are lesser.
Yes. Yeah, and they are at the same level. If you compare ankle on the right to ankle on the left, you can see that the amplitudes are quite low. So it means that there is a problem with this thing. No, this one is like invasive procedure.
Pressure monitoring.
Yes, exactly. Yeah. So there are the waves that we get with inside those arteries. So it's arterial pressure.
Intravascular ultrasound or something like that. Okay,
yes, just like
fine.
what we see during what do you call it? PCI, we see all these amplitude.
Yes.
When they want to do intravenous intervention in the limbs, they show us these waves too.
Thank you. It's a bit clearer.
Please, good evening. Please, what is option D false? Please, can you explain that? I didn't quite get, because talk about sensitivity.
Option D, the sensitivity of the ankle brachial index for diagnosis of peripheral artery disease is increased in severely calcified arteries. So this question is false. Why I said it is it said that, okay, we know that for vessels that are calcified, if pressure is applied, calcified vessels would not collapse effectively. That is, they are not going to be easily compressed, unlike if they were not calcified. So most times, if you have patients who are diabetic, patients who have renal disease, maybe on dialysis, they actually have high incidence of calcification of these vessels. So when these vessels are calcified, maybe if the pressure that you will need to compress it will be much more than the pressure that you will compress another vessel that is not calcified. So that means for these people, they will have falsely elevated ankle brachial index. So that means that for people who have calcified arteries, this test is actually not sensitive. The sensitivity is low. But the option here says that the sensitivity index is actually increased in patients who have calcified arteries. So it's false. Rather, the sensitivity is reduced in patients who have calcified arteries. I don't know if you understand, or if someone can explain it better for us, please. Thank you.
Thank you very much. I think it's clear to me. Thank you.
Okay, thank you, sir. Question 260. Which of the following statements regarding in-stent restenosis is correct? Okay. Which of them is correct? A, less than 1% of percutaneous coronary intervention performed in the United States are to treat ISR. This is a false statement, because when I went to look around, it says that in the US, about approximately 15% of PCIs in the US are actually performed for restenosis. So saying that less than 1% is what we used to treat is false. Diabetes is a risk factor for in-stent restenosis. This is true. Clinical in-stent restenosis is more common with drug-eluting stents than with bare metal stents. This is false. Bare metal stents actually had a lot of complication of in-stent restenosis. And this was the reason why drug-eluting stents were produced, and they actually, since they came out, they are used more because it has reduced significantly the occurrence of in-stent restenosis. Option D, brachytherapy is contraindicated as a treatment for in-stent restenosis. This is false, because in-stent restenosis, actually, for people who have in-stent restenosis, it said that beta radiation can be used to impede the proliferative process that occurs when we have a stent inserted into the vessel. So coronary brachytherapy is actually a treatment for in-stent restenosis. So which of this is correct? The option is B. Diabetes is a risk factor for in-stent restenosis. All the other options are not correct statements. Please, clarifications on the questions and more additions. Thank you.
I'm trying to get a clear picture of what exactly this in-stent restenosis is. So going by the word itself, restenosis means okay.
In-stent restenosis. Okay, sorry, so I'm listening.
Okay, no. Please, let's hear you first. Let's hear you.
Okay, I just want to say that in-stent restenosis means that there is a vessel that was occluded, a stent is put inside the vessel. While the stent is inside the vessel, a restenosis, another stenotic event occurs. So that is in-stent restenosis. The stent is inside the vessel and another stenosis occurs. So that means it's possible that the stent that you put into the vessel has actually caused a kind of reaction. It's a foreign body. So because it's a foreign body, it has attracted an ongoing process to actually cause platelets to gather and cause another stenosis while it is there. Chief, I think that's what is in-stent restenosis. So that is restenosis after a PCI, and is usually due to local proliferation of the tissue there. So it says that it occurs more when there are smaller vessels, when it's a mechanical stent used, when you use a stent, maybe a bare metal stent, it's increased in them. Use of mechanical stents, people who are diabetic, it's common in them. I don't know. Chief, this is what I remember, sir.
You see, you've actually answered my question. Thank you. It's good to listen.
Okay, Chief, thank you.
Okay, so that means, in essence, you're trying to say that this in-stent restenosis is common in patients who actually have a bare metal, like the ones who do not have drug-eluting stents, right? That's what you mean?
Yes, because the
Okay,
ones who have drug-eluting stents, they now have, in this newer generation of drug-eluting stents, they are anti-proliferative agents in it. And these anti-proliferative agents kind of prevent in-stent restenosis because
like it has an antiplatelet activity, like the drug actually has an antiplatelet activity whereby it prevents platelet from aggregating around the foreign body, right? That's what it means.
Yes, Chief.
Okay.
Not,
it's
sorry
not
to
just
chip
called
in, not
antiplatelet, it's called
necessarily. Not necessarily.
They
antiproliferative.
have neoproliferative.
Exactly.
Yes.
So not necessarily anti-platelet drugs. It's more of anti-proliferative.
Okay.
Rather.
Yeah.
So because it's the overgrowth of the tissue that will cause the stenosis. So with the drug-eluting stents, you are basically just introducing an anti-proliferative agent that will prevent this new tissue growth. And for that reason, that is why usually patients who use the drug-eluting stent tend to require longer duration of antiplatelet therapy. So even because you are also as much as possible slowing, it's more or less you are slowing healing process with the drug-eluting stent. You are slowing the healing process by the anti-proliferative activity. And so doing, they are also at risk of atherosclerosis formation. So you usually give those patients dual antiplatelet therapy for longer duration compared to bare metal stents.
Okay. Okay. Thank you.
Thank you very much. This is the end of my questions.
Yeah, thank you so much, Dr. We very much appreciate your excellent efforts. Thank you, and God bless.
Thank you, ma'am.
Yes, I wouldn't know. Is the person to take 261 to 270 available, or we have anyone else from the previous one?
No, I'm around, man. Good evening, man.
Good evening, sir. So
I'm available, man.
Okay, for 261, right?
261 to 270.
Oh, that's great. Thank you. So we hear you. Thanks.
Yes.
Yeah, just good evening.
So I guess you can.
Can I quickly chip in something?
Yes, Prof. Good evening, sir.
It's important to know the difference in the characteristics of the stents. As you rightly said, there is bare metal stent, meaning that there's no drug on the body. It's just made of nitinol mesh, okay? And there is the drug-eluting stent. So now what you need to understand is the drug itself. What is the drug and how does the drug work? And why do you use the drug? So that when they say in-stent stenosis, ISI, that is in-stent stenosis, or they say stent thrombosis, you're able to know the difference and which one is superior, which stent is better for this condition, and which stent will be preferred for that other condition. So there are two major problems that arise when you put in a stent. One, the stent can get thrombosed because platelet aggregates, clot form, and the stent is blocked. Another thing that can happen to the stent is that when the endothelial lining of the coronary artery with the we have the endothelium, we have the middle layer, that is what do you call it now? You know, there are three layers.
Intima.
Intima, yeah. So the endothelial and the intima layer can grow and block the stent. So that one is in-stent restenosis. So there are two different things: stent thrombosis, which is mediated by platelet aggregation, and in-stent restenosis, meaning that the layer walls or the layers of the vessels grew into the stent and blocked the stent. So there are two different things. So, and the treatment is also different. So how do you prevent the two? For the stent thrombosis, the easiest way to prevent stent thrombosis is to put a bare metal stent. The reason is that if you put a bare metal stent, what would happen would be that the to prevent stent thrombosis, is to use stent thrombosis occurs more commonly, acute stent thrombosis occur more commonly in bare metal stents. Okay, so and to prevent that, we usually use antiplatelet for a short period. But in stent restenosis, because the layer of the wall will grow, it would quickly grow to block the stent, that is the stent itself. And if you use a bare metal stent in that condition, there is nothing preventing the growth of the endothelium. So that means the endothelium can easily get blocked. So I want you to give you the two scenarios very well. So when you use a bare metal stent, what can happen will be early stent thrombosis. So if you have early stent thrombosis, if you give antiplatelet for a short period, the stent will be in the vessel wall and the endothelium can grow, right, to accept and grow over the stent. So immediately the endothelium grows over the stent, what would happen is that there won't be stent thrombosis anymore because it's now normal endothelium that is there. I don't know if you understood that part. So a bare metal stent is more suitable for preventing stent thrombosis in the future. Dr. Imolade, do you understand?
Yes, Chief.
I need to be sure.
Yes, I understand.
Dr. Conti, Dr. Briggs.
Yes, Prof. I mean, it's clear. Yeah.
Okay, hello, sir. Just a simple question. Do we have any
Hello, I didn't get the question.
I think she's having network.
It's not me, Adi.
We can't hear her either.
Sorry, Prof. Please, I have a question to ask pertaining this.
Before we do that,
am I still audible?
Okay, sir. Yes, you're audible.
Yes, so ask the question.
Sorry, please, I have a question. Okay, so if bare metal stent is the one that have the complication of stent thrombosis, why are we giving antiplatelets for a short duration? I felt we should give it for a longer duration. I don't know, because I saw that it's giving, usually antiplatelets is given for just 1 month.
Okay, hello, sir.
So if it's a problem with this, why should they give it for a shorter duration?
So you need to get the complications very clear. I need you to get the complications very clear. So this is how it works. Then you'll now understand the complication that can happen. When you put a bare metal stent, I think it doesn't have a drug, have you? So what will happen is that the endothelium will grow, right? Of the coronary vessel will grow into the stent, right? So that means if it goes into the stent, it absorbs the stent. Is that clear?
Okay, yes.
So when it absorbs the stent, that means that you don't see the stent anymore. The stent is already embedded in the wall. So the vessel, the stent at the level you put the stent, what you have after 1 month, 2 months will be that it is normal endothelium because the stent has been absorbed into the wall because the endothelium has grown into the stent. Do you get that, man?
Yes, sir.
So in that case, if this bare metal stent will cause a problem, the really long-term problem is going to cause is in-stent stenosis, restenosis, because the endothelium will keep growing, right? And one layer will, one part of the endothelium will grow to the other part of the endothelium, and it will now block the stent. Do you now understand the in-stent restenosis?
Yes, sir.
Now, but the only problem is that the bare metal stent is good if you give in the early time you use it, within the first month, as the endothelium is growing, the major complication that can happen at the first early month is that they can cause stent thrombosis. Okay? That's why you give antiplatelet for a short period. Because within 1 month, endothelium has grown. Abi? And when endothelium grows, then that means that the stent itself is now inside the wall, not on the outside of, not in the inside of the wall anymore. not in the endothelial layer. It is now in the medial layer because endothelium has grown, or subendothelial layer. So it means that after 1 month, you cannot have stent thrombosis anymore because what you have now is just endothelium, the normal endothelium. I don't know if you understand that.
Yes, sir, it makes sense.
Because the endothelium has grown now, so thrombosis cannot happen after 1 month. Endothelium has grown to swallow the stent. So that is why you can give antiplatelet in them for 1 month just to allow endothelium to quickly grow. So
Okay,
their
sir.
problem is early stent thrombosis. But the long major real problem is in-stent restenosis. Because that endothelium will keep growing and keep growing until it blocks the lumen of the stent. Do you get that?
Yes, sir. Thank
Now,
you.
so to prevent that long-term problem of restenosis is why they now went to make a drug-eluting stent. Now, so the drug-eluting stent, what does it do? It is coated with some drugs. There are different types of drugs. Sirolimus, everolimus, paxilactal. They are different. Now, what are these drugs? These drugs are the same drugs that will work like a chemotherapy or immunosuppressant chemotherapy medication. So they have, like the everolimus, sirolimus now, they belong to the class of mammalian targets of rapamycin inhibitors, mTOR inhibitors. Okay? They are anti-proliferative. They will not allow proliferation. Remember, we said the problem of bare metal stent is that the endothelium will keep growing, right? And keep growing and keep growing until it blocks the lumen of the stent. So what we want to prevent is to prevent the endothelium from growing and growing and growing, right? So you give a drug. I hope I'm still audible.
Yes, you are, sir.
Yes, yeah.
Yes, you are audible, sir.
You will give a drug on that stent that will prevent the endothelium from growing and growing and regrowing. Okay? So that is the treatment for in-stent restenosis, putting a drug-eluting stent. Now, the problem of that is that the moment you put that kind of drug and stent together, that means that endothelium will not grow early, to cover the stent, right? You have achieved one thing, but you have caused one problem. The stent will be naked for a long time because endothelium has not grown to swallow it. So the stent will be naked for a long time, right? So that means platelet aggregation, platelets, and all the problem of thrombosis will not happen in them because that stent is opened for a long time because endothelium has not covered it. So the risk of platelet blocking it is very high in a long period. So the problem of long stent thrombosis in the long duration, because you classify all these things: early stent thrombosis, late stent thrombosis. So there's a problem of late stent thrombosis in this kind of condition. So that is why you will give them antiplatelet for a long time, at least dual antiplatelet for 1 year, because endothelium has not grown to cover that stent. Do you not get the difference? Why one is a short duration and the other one is a long duration? I don't know if I'm clear.
Okay, yes, sir.
Very
You're
clear, sir.
very clear.
It's clearer. It's clearer, Prof. Thank you, sir.
Thank you.
Thank you, sir.
Sorry, sir, just a clarification. So let me be sure, please. So that means from what you explained, sir, it means that the in-stent restenosis is more in bare metal stents, while the stent thrombosis is commoner in drug-eluting stents, sir.
Yes, it's common, especially as I said, stent thrombosis, you classify them as early stent thrombosis and late stent thrombosis. So this stent thrombosis is commoner with drug-eluting stents if you don't give them antiplatelets, or some can even be resistant to the antiplatelets. For example, we all know some people have gene polymorphism for clopidogrel, P2Y12, right? Inhibitors. So those kind of patients would have high risk of stent thrombosis, even 6 months, 1 year down the line, more than a year down the line. You get what I mean? So it's because the stent itself is left naked for a long time, because endothelium has been inhibited from growing. Do you get that? See, when you understand the physiology behind it, you'll be able to understand the complication that can happen, especially for MCQ reasons.
Thank you, sir.
Great. Now, so other problems that can cause in-stent restenosis will be if this vessel is small. You're stenting a vessel that is less than 2 millimeters. Number one, the lumen is so small, you now drop the stent inside this very small, tiny lumen. Then the stent will soon get blocked and stenosis will happen. You get? Number two is if you're using a very long stent, you have a lesion of more than 30 millimeters, and you are now using very long stent to cover that lesion. So the longer the stent, the more it takes, the longer it takes to swallow the stent, for the endothelium to swallow the stent, and the higher the risk of stent thrombosis. And the longer the stent, the higher the risk of in-stent restenosis. So the length of the stent, the diameter of the vessel, and the stent also predisposed to these conditions. Okay, thank you very much.
So, Prof, sir, please, sir, so after for the drug-eluting stent, we give a dual antiplatelet therapy for 12 months. After that, is it then to just switch to a single antiplatelet therapy?
Yeah, you switch to single antiplatelet therapy. I also dropped something on the platform, I think, regarding even triple antiplatelet therapy. When do you use anticoagulants and the durations? I dropped a link on the platform.
Okay. Thank you so much, sir.
For the iris. So that's what you do. You are very correct, sir. Thank you.
Thank you, Prof. Thank you so much. We appreciate. So, Dr. Yes, thank you. Yes, thank you. So I think we can have you now. Some explanation. The subsequent ones should be easier. Thank you.
Prof has made the
Exactly.
for 261 to the law.
Yes, thanks.
Yeah, good evening, consultants, seniors, and colleagues. I'll be taking the aspect of 261 to 270. I hope I'm audible. Hello?
You are audible, sir.
Okay, good evening, sir. Now, I'll be starting with 261. Now, which of the following statements regarding drug-eluting stent is correct? A said the drug-eluting stent stimulates local neointimal proliferation. That one is a false statement because if you look at the earlier explanation, the aim of the drug-eluting stents is they are impregnated with the anti-proliferative agent that prevents late local neoproliferations. That's one of the advantages. Now, the other thing is the generation. There are first generation drug-eluting stents, and we also have second generation drug-eluting stents. Now, the first generation drug-eluting stents are the sirolimus and the paclitaxel, while the second generation are the zotariolimus and everolimus. Now, there was study that compared the first generation, the second generation to the first generation one. Now, zotariolimus was compared with the first generation, especially the sirolimus, and the first set of these zotariolimus were the endeavors. But what they observed in the study was that the endeavors, zotariolimus drug-eluting stents, are associated with late stent stenosis than what was observed in the first generation drug-eluting stent, which are the sirolimus and the paclitaxel. Because of this, they now redesigned the endeavor to the current, the resolute zotariolimus eluting stents, which is what currently is being used. And this was found to be non-inferior to the everolimus in the resolute all-comers trial. Now, the everolimus 2 was also compared to the paclitaxel in the SPIRIT 4 trial in patients with coronary arterial disease undergoing percutaneous coronary intervention. But what they observed at the primary endpoint of the total lesion failure at 1 year was significantly lower for everolimus eluting stent when compared to paclitaxel. Now, additionally, paclitaxel is known to also stabilize the microtubules and prevent the cell division and multiplication. Now, they said paclitaxel, that's B, paclitaxel stabilizes microtubules and prevents cell division. That is the true statement. Now, the drug-eluting stent that incorporates everolimus are less effective at preventing target lesion failure compared to stents that are incorporated with paclitaxel. This is false based on the SPIRIT 4 trial, where they observed that the primary endpoint of total lesion failure at 1 year was significantly lower in everolimus. Now, the zotariolimus drug-eluting stent significantly reduced the frequency of late stent thrombosis compared to sirolimus. This is a false statement too, because if you observe, I said in endeavors zotariolimus eluting stent, what they observed was that they are associated with late stent restenosis compared to the first generation drug-eluting stent. Based on this now, the correct answer here will be B. The correct answer will be B. I hope I'm still audible. For any clarification or addition, yes, for further clarification or addition or correction, but based on what I have read, the B stand to be the true answer in 261.
Sorry, aside the everolimus, being a second generation drug-eluting stent, which other is there a second one, or just that alone?
Yes, okay. There's the zotariolimus. Zotariolimus is the second one. Okay. We have the zotariolimus and the everolimus. These are the second generation, and they are both analog of rapamycin.
Okay. Thank you.
Okay, can I go ahead? Okay, 262. Which of the following is an effect of regular exercise? A, favorable changes in fibrinolytic system. B, decreased heart rate variability. C, decreased expression of nitric oxide synthase. Decreased high density lipoprotein cholesterol. Increased systolic and diastolic prayer. Now, the effect on regular exercise on the fibrinolytic system. Now, it has been observed that those group of people that engage in regular exercise, that they have decreased level of fibrinogen and also decreased level of plasminogen activator inhibitor 1, with an accompanying increase in tissue plasminogen activator level. What this means is that in those set of patients, if at all they even develop thrombosis, this increased level of tissue plasminogen activator level, which are responsible for the conversion of plasminogen to plasmin, will assist with the lysis of the thrombus that are formed, meaning that they are favorable. They give a favorable changes in the fibrinolytic system. This A option is a true statement. Now, the effect of regular exercise on the autonomic system, they observe that they have a reduced parasympathetic tone that increase the heart rate variability. The B is false, is rather an increase in heart rate variability because of its effect as of the effect of exercise on parasympathetic activities. Now, exercise is also associated with increased expression of the nitric oxide synthase and increased production of nitric oxide, also making this one to be false. Now, the effect of exercise on the lipid profile, they are associated with decreased triglyceride, decreased low density lipoprotein cholesterol, and an increase in high density lipoprotein cholesterol, also making this D to be false. Is an increase in lipoprotein cholesterol, and there's an improvement. They are associated with decrease in systolic and diastolic blood pressure, making the answer A is actually A. That's for 262. I don't know if there's any clarification or addition to this. Hello? Hello?
You can go on.
Okay, 263. Which of the following is not a major determinant of myocardial oxygen demand? Now, the three main determinants of myocardial oxygen demand are: 1, the heart rate, the ventricular wall tension, and the myocardial contracture state. However, the ventricular wall tensions are directly proportional to the aortic pressure and intraventricular volume that is observed in that stroke. Now, if you look at this option now, they said A, ventricular wall tension, we are looking for a false statement. Ventricular wall tension here is true, making it false here. The plasma hemoglobin level is not a determinant of myocardial oxygen demand, rather a determinant of oxygen supply to the myocardium, making this one to be wrong and making it to be the answer here. Now, the myocardial contracture state is also true. The heart rate is true, and the E option too is also true. The answer A, which is B, is a determinant of myocardial oxygen supply, not myocardial oxygen demand. I don't know if there is any clarification or addition before I go to 264. But additionally, on question 263, but we should know that in those people that engage in prolonged and regular aerobic exercise, they are associated with an areas of cardiovascular adaptation that we regard as athletic acts. And such changes that they usually have are: 1, they have increase in resting systolic volume. They have decrease in resting heart rate. And the reason they have this decrease in resting heart rate is because of the increased resting vagal tone, making them to have a decrease in resting heart rate. Now, they have this resting tachycardia, which also may be associated with marked sinus arrhythmia, the various degree of AV blocks. And they are also known to have ST changes, early repolarization ST segment changes, and ST T-wave abnormality that can be found. They are also associated with an increase in LV wall thickness, usually an eccentric level vascular hypertrophy. You also have mild dilatation of the right ventricle with the thickening of the right ventricular wall. They also have dilatation of the atrium. The systolic function, the left systolic function are usually normal, usually in the lower range. And these can be reversed once the patient stops this regular aerobic exercise over 6 to 34 weeks of abstinence from the exercise. Now, those are just the addition on 263. Can I go ahead? Question 264. A 63-year-old man with long-standing insulin-requiring diabetes presented to his physician office 2 weeks ago for management of hypertension. 63-year-old man, long-term insulin-requiring diabetes, that presented 2 weeks ago for management of hypertension. His blood pressure was 160/94 millimeter of mercury. His serum creatinine was 1.6 milligram per dl, and the blood urea level of 30, both of which were elevated. However, with an otherwise normal serum chemistry. Now, a potassium-sparing diuretics was prescribed. When he returned 2 weeks later, the serum potassium level is 6.8 millimole per liter, with no significant change in the blood urea nitrogen or creatinine level. The most likely contributing mechanism is 1. Now, analyzing this question now, this is a 63-year-old woman, long-term issue of diabetes, inquiring insulin. He has developed elevated blood pressure with an elevated blood urea and nitrogen and the creatinine. Likely the patient has developed chronic kidney disease secondary to diabetic nephropathy. Now, if you remember very well, the source of renin production is the juxtaglomerular apparatus. Now, in those people that have chronic kidney disease, now there is defective production of renin, meaning that they have hyporenemia. And you can remember the functions of the renin on the renin angiotensin-aldosterone pathway, meaning that if the renin is defective, there will also be defective production of aldosterone. Now, asking this question, they said the most likely contributing mechanism is 1, excessive consumption of bananas and tomatoes. Yes, this was not mentioned in the question, though banana and tomato are good source of potassium. 2, a recent urinary tract infection was also not mentioned in the question. Now, primary hyperaldosteronism. Primary hyperaldosteronism would rather be associated with hypokalemia, not hyperkalemia. Now, the D option is the likely answer here, hyporenemic hypoaldosteronism, which with the hypoaldosteronism, we know that there will be retentions of, there will be reabsorption of sodium, meaning that there will be retention of potassium. Now, likely the late addition of this potassium-sparing diuretics was just a trigger to the background mechanism that is ongoing here. Cushing 2 will also be associated with hypokalemia rather. Now, the likely answer here is D, which is hyporenemic hypoaldosteronism. I don't know if there's any additional clarification before I move on. Hello? Okay, question. Hello?
You can move on, it's well understood.
Okay. Now, question 265. Now, which of the following statements about the use of prasugrel is not correct? They say A, compare with clopidogrel, platelet aggregation is more effectively inhibited by prasugrel. That is a true statement, because we are looking for a false statement that make that option A to be false. One of the attributes of, but we should know that the prasugrel, the clopidogrel, they all belong to the same class of P2Y12 ADP receptor inhibitors. Yes, they all belong to the same class. But what has been observed in prasugrel is that they are less susceptible to genetic variation. They are less susceptible to drug-drug interaction. The active metabolite, because the two of them are prodrugs, the active metabolite have a similar antiplatelet effects in equimolar concentration. They are more rapid in onset, they are consistent, and they have a higher inhibition of ADP-induced platelet aggregations. Now, in there was a trial in which they compare those patients, they had acute coronary syndrome and they have PCI, and they randomized them into those arms that have prasugrel and those arms that have clopidogrel in a 3-ton CME38 trial. Now, what they observed is that those patients that had prasugrel, when they follow them up over 15 months, they realized that 19% of those people that are on prasugrel have reduced cardiovascular outcome of cardiovascular deaths, myocardial infarction, and stroke. They also have 50% reduction in the risk of stent restenosis. However, they noticed they have an increased rate of fetal bleeding when they compare to clopidogrel, especially in elderly patients that are more than 75 years old, people that have prior history of stroke or transient ischemic attack, and those that have weight that are less than 60 kg. The implication of this is that in those set of people, they'll be careful, or there will be a contraindication to their use, so one will be very careful in using those class of drug in those set of people. Now, going back to the question. Now, A, compared with clopidogrel, platelet aggregation is more effectively inhibited by prasugrel. That is a true statement. B, compared with clopidogrel, prasugrel reduces the risk of stent thrombosis. That is also true. Now, compared to clopidogrel, bleeding complications associated with prasugrel are lower. This is a false statement. We are looking for a false statement. That makes C to be the likely answer here. Prasugrel is contraindicated in those patients with history of stroke. This is a true statement. The risk of bleeding with prasugrel is higher in patients that age more than 75 years of age. That one is also true. The answer here is C. The answer here is C. Now, I don't know if there's any clarification or question before I move on to the next stage, which is question 266 to 269. I can go ahead.
Yes, you can.
Okay, ma. Now the question says match the following cell types involved in atherogenesis with the appropriate descriptive phrase. Now, those are the options. A is endothelial cell, smooth muscle cell, macrophages, and platelets. Now, the question now is question 266, demonstrate proliferations in demonstrate proliferation in the intima in atherosclerosis. Now, as a brief introduction, we should, as we all know, that the endothelial cells, they lyse the entire vascular trace, and they are coated on the surface with heparin sulfate that reduces the thrombogenicity in them. The endothelial cells also produce prostaglandin derivatives, especially prostacyclin, that are responsible for vasodilation, and they inhibit platelet aggregation. They also secrete tissue plasminogen activator, which contributes to the lysis of fibrin clots. And it's also producing nitric oxide. Now, in the pathogenesis of atherosclerosis, now the initial thing in the process is the endothelial dysfunctions. With the endothelial dysfunctions, as a result of the exposure to cardiovascular risk factors, there is injury to the vascular wall, there is increased permeability, cytokines are produced. Those macrophages, those monophages that are on the vascular lumen find their way through the appendices into the intima. Now, within the intima, the macrophages, the monophages are converted to macrophages. And once they get there, they were able to pick up those oxidized LDL cholesterol that have also find their way into the intima. Once they pick up those LDL cholesterol, they become the macrophages-laden cells or foam cells. Now, once they are within the intima, they have the ability to be able to proliferate and produce cytokines that draws smooth muscle cells from the usual place of the media. They're usually in the media. Under the influence of that cytokines, the smooth muscle cells also migrate into the intima and is responsible for the intima hyperplastic lesions that you observe in atherosclerosis. Now, going by this brief introduction, we said which one demonstrates proliferation in the intima in atherosclerosis. It's the smooth muscles that usually proliferate because their usual place is the media. They now find their way, goes into the intima. That makes the 266, the option here is smooth muscle cell, is B. 266 is B. Now, the 267, they say is or are the principal cells of the fatty streaks. Now, this will be the macrophages, meaning that the option is C. The one that secretes prostaglandin are the endothelial cells, making it A. Is capable of little of no protein synthesis. Is the platelet, that's D. The platelet does not proliferate. I mean, they do not synthesize. Rather, they release those foam granules into the circulation. I don't know if there's any clarification based on 266 to 269. Hello? Hello? Hello?
Hello, please continue. Good evening, everyone. Please continue.
Okay, good evening. Now I'm on question 270, which is the last question. It says, for each statement, match the corresponding beta blocker. The option 270 here, it said, which one has alpha and beta receptor blocking activities? Now, there are 3 generations of beta blockers. We have the first generation. Those are the non-selective. They block both beta 1 and beta 2. And we also have the second generation, which are cardioselective. They block the beta 1. We now have the one that have the additional alpha. Those one has vasodilatory effects. Those are the class 3. Those are the carvedilors, are the one that has alpha and beta blocking activity. These are the 3rd generation beta blockers. The answer for 270 is B. It's B. I guess that's the last question for me.
Okay. Good evening. Can I just add something to the discussion on beta blockers?
Very free.
Okay,
Thank
so
you.
Okay, generally we classify them based on their cardioselectivity. And then another thing to remember is their intrinsic sympathomimetic activity. So we'll classify them as one, either they are beta 1 or they act on both beta 1 and beta 2 receptors. So within the beta 1 or those that act on beta 1 or those that act on beta 1 and 2, you will have those that have intrinsic sympathomimetic activity and those who don't have. Okay, so for example, if we talk about the beta 1 selective, that's those that are cardioselective, that are beta 1 selective. The ones that have intrinsic sympathomimetic activity are drugs like acebutolol and celiprolol. But majority of the beta 1 selective that we know, they do not have intrinsic sympathomimetic activity. And those ones include beta 1 selective beta blockers like atenolol, the common bisoprolol that we use, metoprolol, and nebivolol. Okay, so on the other end, the ones that act on both beta 1 and 2 receptor, there are also those that have sympathomimetic activity, intrinsic sympathomimetic activity, and those that don't have. So among those that have intrinsic sympathomimetic activity that act on both beta 1 and 2, you have the alpranolol. They are not very common. The alpranolol, catriolol, pindolol, those ones. Then those without intrinsic sympathomimetic activity but act on both beta 1 and beta 2 receptors are the more common ones, like the propranolols, the carvedilol, the nadolol. Okay. So what we mean by intrinsic sympathomimetic activity is that there are a group of beta blockers that are capable to, they have the ability, they act like agonists at the beta adrenergic receptors. Okay. So their activity is such that they are able to oppose catecholamines in a competitive way, but they are able to stimulate beta adrenergic receptors and compete against catecholamines. And there are conditions in which we would favor or use these beta blockers. Then another thing is that there are beta blockers that have high lipid solubility and those that have high water solubility. So among those that have high lipid solubility, I think it's important to remember propranolol is one, metoprolol is another, and then timolol, MPT, metoprolol, propranolol, and timolol, they have very high lipid solubility. While in terms of high water solubility, the popular atenolol comes there, sotalol, nadolol. There are examples of those that have high lipids and high water solubility. Thank you.
Thank you, sir.
Please, can you send it to the group for us, please?
Okay, I'll do that. Okay.
Do you have any code for the hydrophobic ones? No, hydrophobic ones, I should say. The water soluble.
What I usually remember, I don't have a code for the water, but I remember the lipid one by just saying MPT. MPT, yes. Metoprolol, propranolol. If you can, propranolol, it's non-beta 1, beta 2. So metoprolol, propranolol, timolol. I know those three they have high lipid solubility. Then if we can remember the other beta blockers we don't use very commonly, like nadolol, atenolol, sotalol, celiprolol, those ones we don't use them commonly. They are more, or they have higher water solubility. Thank you.
Please, examples
I think
of
you can use
drugs
the
that
SAS
have
for the code for hydrophilic, like SAN.
Yes, SAN or you want
Okay. Thank you. SAN, yes, sir. sotalol, atenolol, nadolol. Thank you very much.
Thank you, sir. Question 270 marks the end of my own aspect of the question. Hello?
Yes, we can hear you. Thank
Yes,
you so much. Yes, we heard you. Thank you. We are grateful for these excellent efforts. God bless you. Thank you.
Thank
I
you.
don't know who else is available. I don't know. I think Dr. Deonju is here. I don't know the numbers that we had missed earlier. If the people to take the previous ones we skipped, if we still have, before we go too far.
Okay. Thank you so much, Dr. Moladi. Thank you so much for holding forth. I'm sorry I was on call. Good evening to all the chiefs on the platform. I know that last week, Dr. Miriam Oji was trying to present. I don't know whether she has taken her part today.
No,
I've
she
not.
hasn't.
Good evening, all. Good evening, ma. So sorry
Good
about
evening,
last.
all.
Yes. Is it possible that you take today? Is your network very stable now, ma?
Okay, I'll try.
Thank you so much.
Can you help me share the slide, please?
You need to tell us the number.
I think it's 211
Okay.
to 220, right?
No, 221. 221.
Okay, thank you.
I've actually done 221. Or should I go over it again? Or I don't know.
Yes, please go over it again. Thank you.
Okay, I should go over 221 again. All right. The question goes there, okay, we're here together. 221 says, which of the following statements regarding antithrombotic therapy and the treatment of unstable angina and non-ST segment in myocardial infarction is not correct? Okay, we know that unstable angina or SMI, they are typically caused by atherosclerotic plaque destruction with fragmentation of platelet-rich intracoronary non-occlusion. So here, there was several trials that was done in the management of acute unstable angina and ST segments that was called. Originally, we know that the main treatment of unstable angina and MCQ is aspirin, which can be used alone. However, in the trial, they tried combination of clopidogrel and aspirin alone. So in the CURE trial, it demonstrated that the addition of clopidogrel results in reduction of 20% death in death, also in MI and stroke. It was also shown that the effect of clopidogrel begins within 24 hours of administration and persists for over 12 months. So another trial that was done was the one they tried the addition of anticoagulants. The one they tried was the unfractionated heparin and the low molecular weight heparin. In that trial, it was noted that compared to low molecular weight heparin, unfractionated heparin leads to reduction in recurrent MI or even new MI. However, they have increased risk of bleeding. Hence, sorry, I said that for both of them, there was no difference in the reduction of MI or recurrent MI. But when you talk about unfractionated heparin, they have increased risk of bleeding. Hence, enoxaparin, that's low molecular weight heparin, is preferred over unfractionated heparin because of the increased bleeding. Are we there?
We can
Hello,
hear
can
you.
someone hear me? Okay. Then another trial that was done was the Assessemt study, which compared fondaparinux and enoxaparin. It was noted that fondaparinux, there was reduced risk of major bleeding or after 30 days in a patient that was on fondaparinux compared to enoxaparin. Hence, enoxaparin is more preferable to and fondaparinux is more preferable to enoxaparin because of the increased risk of bleeding. In ACUITY trial, where they compared biliverdin, they combined it with glycoprotein 2B 3A inhibitor, and also compared it with other drugs where they compared unfractionated heparin or low molecular weight heparin with glycoprotein 2A 2B. In both arms, there was no difference in ischemic events, but those ones on biliverdin have less bleeding. So when you combine it with aspirin or clopidogrel, it's another alternative that can be used because of the reduced risk of bleeding. So can we go over to the question now? Question A says that the early beneficial cardiac outcome effect of clopidogrel in acute coronary syndrome persists for 12 months after hospital discharge. That's a true statement. Remember that we said it takes effect within 24 hours and persists for 12 months. B option says the combination of aspirin and anticoagulants prior anticoagulant is superior to aspirin alone in preventing death, non-fatal MI, and acute treatment in acute coronary syndrome. So this one now, it was not better when you combine the clopidogrel. When you use aspirin combined with anticoagulants, it's prior to using aspirin alone. That's also a true statement. Remember that we said when you combine them, it reduces the risk of death, even stroke, not just only the coronary artery disease. Number C option says that anticoagulants with low molecular weight heparin, enoxaparin, is superior to unfractionated heparin in reducing the rate of death, neofatality, and recurrent ischemia. When we talked about the trials done comparing the low molecular weight heparin enoxaparin, and unfractionated heparin. We say that it's preferred because of increased risk of bleeding. So that statement is also true. The option says that comparing enoxaparin treatment of acute coronary syndrome with factor 10 inhibitor, which is fondaparinose, results in statement. Remember that we said that fondaparinose is preferable because of lower risk of bleeding. Hence, the answer to this question is D. The option says the valvulotomy therapy alone is non-inferior to combination with low molecular weight heparin plus glycoprotein 2B3A inhibitor for prevention of ischemic endpoints in patients for whom invasive strategies. Actually, the was actually tried for those people that want that are to undergo invasive therapy. And this statement is also true. Like we said, there was no difference in both arms, whether you combined it with or without. There was no difference. However, it has reduced risk of bleeding. Please, contributions for this one, please. The answer is D. Hello, everyone.
Reverend sister, can go on. You've done a great job there.
Okay, question 22 says, which statement regarding coronary collateral circulation is false? Okay, say that, know that there was already a pre-existing collateral vessels, and there are small vessels ranging about 20 to 200 micrometers in diameter that connects the epicardial coronary arteries. Usually they are non-functional, they are rudimentary, but in acute, when you have acute coronary occlusion, there's going to be rapid drop below the obstruction. That will now lead to increased pressure, because ordinarily there was no pressure in the collateral vessels. But once the pressure below the obstruction drops, the collaterals will immediately opens gradually. And however, once it opens, they have three major events that occurs following that. First one is in the first 24 hours, there's going to be passive widening due to increased flow. Then over the next several weeks, the flow, due to increased flow and shear stress, there's going to be trigger of endothelial cell damage, leading to inflammation, cellular proliferation, and also damage the basement membrane. And also there's also going to be destruction of the position of extracellular matrix and recruitment of leukocytes. These are the events that will happen following the weeks after that. But over months, the collateral vessel wall will become thickened. They will have like 3 layers, and these vessels that are formed cannot be distinguished from the ordinary normal collateral coronary arteries. So can we look over to the question? We should know that they said that what actually triggers the development maturation of the collateral is a severity of the occlusion. That is what triggers it. However, we talked about that there was no study showing that exercise activates platelets. They said that whatever due to increase in conditioning, the current exercise and they've been doing is not because of not because of obstruction. That wasn't what causes the endurance myocardial infarction that is reducing them. So going back to the question, you say, which of the following regarding collateral circulation is false? We're looking for the false statements. A says that the pre-existing collateral vessels opens immediately after coronary occlusion. They didn't tell us now whether it's acute or it's actually a chronic. But when we have acute occlusion, it actually opens immediately. So that statement is a true one. B, increased blood flow through the pre-existing collateral vessels trigger maturation process that produces a vessel nearly indistinguishable structure from normal collateral artery. That's also a true statement. Exercise does not increase collateral circulation formation. That one is also false. Sorry, that one is also true, because remember we said that what triggers collateral circulation maturation is rate of is severity of the occlusion. So exercise does not. That one is also a true statement. The collateral vessels can produce nearly as much blood flow as native coronary circulation. This is a false statement. They said that the collateral vessels can produce just less than 50% of the circulation compared to normal coronary vessels. So the first option there is option D. E, in the setting of acute coronary myocardial infarction, the presence of pre-existing collateral vessels decreases the infarct size and improves survival. And that's actually a true statement. They say that it actually decreases the collateral size, it decreases the infarct size and also improves survival. So the wrong statement there is option D. Please, contributions from the house. Hello, everyone.
I think.
Oh, can you hear me now?
Yes, we can hear you. It's okay. Let's look at the network. It's still stable now.
Okay. Should I go ahead?
Yes, please.
Okay. Option 223 says that a 72-year-old woman is evaluated for intermittent exertional chest discomfort. During stress testing, she had an exercise capacity of 8 metabolic equivalent, and the nuclear imaging demonstrated moderate ischemia in the in the lateral wall. Coronary angiography showed 80% proximal stenosis of a large first obtuse marginal branch. The left ventricle ejection fraction was normal. Her chest symptoms is less frequent after starting metoprolol, aspirin, and statin. Her heart rate is 76 beats per minute. Blood pressure 130/80 millimeters of mercury. Which of the following statements regarding pharmacological therapy versus revascularization for chronic stable angina is correct? Okay, there were actually some studies done comparing revascularization to normal therapy in chronic stable angina. And one of them is the one we call Courage trial. In Courage trial, they randomized the percutaneous coronary intervention plus optimal therapy. That's those people that were already on aspirin, statins, ACIs. So they compared two of them. After 4 to 6 years of follow-up, there were no reduction in death or MI in patients randomized to PCI compared with those on medical therapy. So that's for Courage trial. We have another trial they call ischemic trial. Ischemic trial randomized the stable coronary patients and stress testing induced to less and moderate ischemia to strategize vascularization versus optimal medical therapy. One thing in this ischemic trial was that they did angiography, CT angiography, to exclude those with left main disease. And over 3 years, patients who underwent revascularization, they have greater symptomatic improvement, but there was no difference in the endpoints like death, cardiovascular death, MI, unstable angina, heart failure, or in those patients that was revascularized compared to the other people that are on optimal therapy. So can we go to the question and see what we have? Please, are we there?
We're here with you.
Okay. Option A says that revascularization should definitely be the next step given to her persistent symptomatic symptoms on current pharmacological regimen. Remember that we said that when you do revascularization, it can only reduce symptoms. And this patient, they said that the chest pain is less frequent after starting metoprolol. They're already improving. So when you do, according to Courage trial, if you do revascularization in them now, we are not going to do much because it's only symptomatic relief that was more in them compared to ordinary therapy. The correct one. B, percutaneous coronary to pharmacological therapy alone in reducing cardiovascular mortality in patients with chronic angina. Remember that when they still in the same Courage trial, there was only symptomatic relief, but no actual thing. It does not really relieve, improve the mortality in them, just only for the symptomatic relief. In ischemic trial, option C, patients with chronic artery coronary artery disease who underwent revascularization had improvements in angina symptom compared to those who received pharmacological therapy alone. That was a true statement. Remember that we said that in ischemic trial, it was just only still the symptoms that was improved, but there was no endpoint improvements in both arms. Option D says that results from Courage and ischemic trial applied equally to patients with significant left main stenosis as those with high-grade single vessel disease. That's a false statement. The main coronary, left main stenosis was excluded only in ischemic study, but not in Courage study. So that makes option D false. So the correct answer here is option C. Any contribution, please, from the house? Hello?
Sister, you can go on.
Hello, everyone.
You can go on, sister.
All right. 224. Which of the following statements?
Sorry, before you go on, in case I go off sharing, I don't know, can someone please share its battery is down? Sorry for the breaking.
Okay, thank you.
Yeah, wait.
Okay.
Please,
Okay,
who else
224.
can share,
Which of
actually?
I'll try and see if I can share with my phone.
Okay.
Okay, thank you, Florence.
Please continue.
Okay, if it goes off.
Yes, by the time. Thank you.
Thank you, Florence. Which of the following statements regarding surgical management of abdominal aortic aneurysm is correct? Okay, we are still also looking for a correct answer here. They said that abdominal aortic aneurysm actually Hello? Okay. Sorry, I muted myself. Sorry. Can you hear me now?
Yes, you are audible. Please continue.
Okay, say that abdominal aortic aneurysm expands by the rate of 0.4 centimeter per year, though the larger ones tend to expand faster than the smaller ones. And once there's a rupture of aortic aneurysm, mortality is extremely very high. Say that about 60% of the patients will die before they reach the hospital. And 50% of those who succeeded in getting hospitalized will also die pre-operatively. So the mortality is very high. So there was also now a surveillance is recommended for abdominal aortic aneurysm. Once you have greater than 4.5 cm, CT another thing we should know that is that CT is better in surveillance compared to abdominal ultrasound, compared to ultrasound imaging, because it can delineate the measurement very well. However, ultrasound cannot give you the actual measurement. So they say that once the aortic aneurysm gets up to 3 to 3.4 centimeter, it should be the recommended frequency of imaging is every 3 years for 3 to 3.4. 3.5 to 4.4 should be done every 12 months. And once it gets to 4.5 to 5.5, it should be done every 6 months. Another thing we should note is that women have a higher rate of a rupture of abdominal aortic aneurysm compared to men. And also, when the diameter is smaller, it's also they can also rupture. Another risk factor for rupture is common in those people that smokes and those with hypertension. Apart from female age, smoking and hypertension is another risk for rupture of abdominal aortic aneurysm. There was a trial done whereby they talked about immediate repair of aneurysm of 4.4 to 4.5. After the survey, it was noticed that there was no difference in mortality between those people that was under surveillance and those people that underwent repair. So can we go over to the question? Option A, so we're looking for the correct one. Option A said that small aneurysm enlarges faster than larger aneurysm, larger ones. That's the false one, because we said that it enlarges about 0.4 centimeter per year. However, the larger ones enlarges faster than the smaller one. Option B says that aortic aneurysm grows and ruptures at a greater rate in men than in women. That's also a false statement, because we say women, those people that smoke and the hypertensive patients have a higher risk of rupture. Option C says it is greatly safe to wait until aortic aneurysm is 6 centimeters or more in diameter before procedure with surgical repair. That's actually a true statement, because we said from 4.5 5. Okay, thank you, Florence. Are we back on?
Yeah, we're back on, but I think she's gone. Let me see what I can share.
Okay, thank you, Florence. Thank you, Chief.
$224.
Okay, we are there now, right? 224, right? Hello, sister.
Yeah, we're not yet
Okay,
there. 224.
I'm there now. Are you seeing it?
All right, thank you. Thank you.
All right then.
Okay, option C says that it is generally safe to wait until aneurysm is 6.0 cm or more in diameter before proceeding with surgical repair. That's the first statement. They said that once aneurysm is 5.5 to 6 centimeter, they have about 30 to 60% risk of rupture. And it's even more when it gets to up to 6 centimeter. Hence, you don't wait until then. Once you get to 5.5, there's need for you to go in for repair. So that statement is also false. Option D says, with aneurysmal rupture, 60% of patients die before reaching hospital. That's a true statement because 60% dies before they get to the hospital. And 50% of those people hospitalized will die preoperatively. Option E says, in men, surgical repair of aneurysm with diameter of 4.5 to 5.5 offers a mortality benefit over continuous surveillance. That's a false statement. The study done said that there was no benefits. It did not reduce the mortality. So surveillance is still preferred until you get to 5.5 to 6 points, to above 5.5. So answer to 224 is D. Please, contributions to.
Hello,
How?
Something I should engage with. How do I do that, please? And okay, enlarge. Are you seeing it better?
Yes, you can see it.
Okay, Reverend Sister, there was something you were saying about different diameters and how often we should follow up on these patients. I didn't get that. Like if it is 3 to 5.5, you follow up on is this 6 monthly? I don't remember. Okay, can you just recap that? Sorry.
Okay, how often you survey?
Yes.
Okay, from 3.0 to 3.4, you do it every 3 years. From 3.5 to 4.4, every 12 months. So from 4.5 to 5.4, you do it every 6 months, because from 5.5 now surgical repair is required.
Thank you.
All right.
I think you can.
Can I go ahead?
Yes, you can.
Okay. Question 226. Which of the following statements regarding abdominal abnormality in the figure 2.5 is correct? Please, can we, okay, we are looking at the image shown there. So what I can see from the image is a CT chest, contrast enhanced computer tomography of the chest that is showing aortic aneurysm. However, I'm having a problem with describing this picture. I don't know if anyone can help, because this place now, I can't show whether, I know that it's an aneurysm, but I don't know whether it's above the subclavian vessel, how to know whether it's up or low aneurysm. Is there anybody that can help with the diagram? Because I tried to understand the diagram. I don't know how to differentiate them.
Well, let me just try. I think that there is an arrow in that central aorta, if you can look at it very well. I think it's a flap rather than an aneurysm. I think it's a dissection rather.
Okay, it's a dissection.
Yes, that's what I think.
Okay.
You can see a flap at the edge. I mean, at the, let's say the closer to your right hand, you can see like a line inside.
Okay, I've seen it.
Yes, I think that's showing you that there is a flap, a dissection flap.
Sorry, do you know how I can use a cursor using my phone? Is it possible?
I'm not so sure about.
Thank you.
And tell us in class. Then if you look at the, I think this one at the lower part is the descending aorta, the one closer to the, would that be the spine? You can see that there is another, like a line inside the contrast enhanced structure.
Yes.
That line is a dissection, like an intimate tear. So it's a flap inside it. Is a dissection.
Okay, so this is actually aortic dissection.
Yes, affecting maybe the ascending, then I think this part of the descending too is there, if I'm right, but I'm subject to corrections. Thank you.
Okay, thank you. Let's get to the question. Thank you so much. Question A says, without treatment, expected mortality is approximately 5% in the first 24 hours. Okay, if this is actually aortic dissection, they said that in the first week, the mortality rate exceeds 25%. Okay, it said it exceeds 50% in the first week. However, in the first 24 hours is more than 25%. So that statement is false because it's not 5%, rather 25% in the first 24 hours. But if it's after first week, it's greater than, it's up to 50%. Okay. Option B, outcome with pharmacological therapy are equivalent to surgical repair in management of this condition when it occurs proximally. Okay, that one is also a false option because based on our classification, we say that once it's proximal, it's an emergency. That's using the Stanford classification. A is proximal above the origin of left subclavian. So once it's there, the dissection occurs there, it needs surgical. But when it's below, you can do medical intervention, except when they are hemodynamically compromised. So that's when you can now do surgery. So that statement is also a false one. Sorry, outcome is, so that one is false. Option C say that initial pharmacological therapy without surgery is recommended when the condition is distal in location and uncomplicated. That's a true statement. Remember, we are looking for true statement. It said if it's proximal, irrespective of anything, you do surgery intervention. But once it's below the subclavian vessel, you now have to do pharmacological, except when there's complications. That one is the true statement. Aortic valve replacement is universally required when there is accompanying aortic regurgitation. It's not actually true statement because what we do normally is you have to do pharmacological therapy. You reduce the, once the aortic valve, you should do pharmacological therapy. First, except you are going to repair the valve, you don't replace it. Once it gets to the replacement, it's not the first thing you do. First thing you do is that you try pharmacological therapy before you now do the repair. It's not the replacement that is the optimal therapy. Option E says labetalol should be avoided in patients with this condition. Actually, the preferred drug to be used here is you can use labetalol. That's the beta blockers. You can also use calcium channel blockers. So that makes that statement. Is there any questions here, please? Hello, can you hear me, please?
We can hear you, sister.
Okay. So can I go ahead?
Go on.
Okay. 226. A 65-year-old man with cirrhosis Florence, you are off. Okay, a 65-year-old man with cirrhosis. Okay, a 65-year-old man with cirrhosis and chronic stable angina presents to the cardiovascular clinic for evaluation. He described typical angina pain, typical angina climbing one flight of a stair despite beta blocker and long-acting nitrate therapy. Stress testing with nuclear perfusion imaging confirmed exercise-induced reversible ischemia on the anterior left ventricular wall. The left ventricular ejection fraction is 50%. Hello, Florence.
Dr. Florence.
I'm so sorry. I'm so sorry. I'm sorry, dear. I'm sorry.
No problem. Thank you for sharing for us. We appreciate you.
Okay. The ejection fraction is 50%. Coronary angiography revealed a long occlusion of the left anterior descending artery in the mid-segments with collateral perfusion of the distant vessel from the right coronary artery. The lesion is not amenable to percutaneous intervention. You are hesitant to increase beta blocker and nitrate dose because of the risk of the heart rate is 50 beats per minute, and the blood pressure is 102/78. Which of the following statements is correct? Okay, option A says ranolazine would decrease blood pressure and heart rate further and should be avoided. We are looking for the correct answer now. That one is a false statement. Ranolazine is also an anti-angina agent that may be combined with other typical agents like beta blocker, calcium channel blocker. However, the difference between them is that it does not act on heart rate or blood pressure. So we can actually use it in this condition because we are worried about the heart rate and the blood pressure. It does not affect the blood pressure. However, it acts by inhibiting the slowly inactivating sodium currents. And also another thing it does that when it inhibits it, it now reduces the influx of sodium and calcium overload that occurs in people with MI. However, there's another problem with the ranolazine. They said that it can, in a study done, it was shown to decrease it was shown that it increases the refractory period and increases the QT interval. Hence, it can lead to torsade pointe. So that's another thing you can have with this, but it did not show to increase any form of angina and any other form of any effect on the blood pressure. So going to question B, said ranolazine does not offer incremental anti-angina benefits to patients already taking beta blocker, long-acting nitrates, or calcium channel blocker. It's actually a false statement. It offers more benefits because now like this one that we don't want the blood pressure and the heart rate to reduce. When we use it, it's going to be safer in them compared to those people that have that on beta blocker. Okay, Compared to placebo, ranulozine increases the risk of torsade pointe. That's also that one is a true statement. Hello, can you hear me, please?
We can hear you, sister.
Yes. Okay. Option D says ranulozine is metabolized in the liver and should be avoided in patients. Ranulozine is metabolized in the liver by cytochrome P23A and is contraindicated in patients with severe liver disease. That's a true statement because that's where it's metabolized. Option E says the common side effect of ranulozine is diarrhea. That's a false statement because the common side effect is dizziness, headache, and constipation rather than diarrhea. That one is also a false statement. Is there any contribution?
You can hit the ball rolling.
Okay. We have 227. Which statements regarding abnormality labeled A in the figure 2.6 is correct? Okay, this is actually a contrast enhanced scan of the abdomen showing the structure label A is actually an abdominal aneurysm because the aorta, abdominal aorta is actually dilated. That's what the diagram is showing. So they are not asking us what the true statement and the false statement regarding it. So they said that majority of the patients are asymptomatic. We are looking for the correct statement. Actually, majority of them are symptomatic when they present, and it is said that actually how you can differentiate them is that when you touch the abdomen, they can actually be pulsatile, and it enlarges from the Ziffert process down to the umbilicus. So question B says that option A is false because it's usually symptomatic. Physical examination tends to underestimate the size. Actually, the physical examination can underestimate the size. That's also a false statement. When you do abdominal examination or physical examination, you can overestimate it, not underestimate it. It's difficult for you to differentiate it from the adjacent statement. Option C says that imaging by ultrasound is usually non-sufficient to plan surgical repair. That's a true statement. You can use do ultrasound to get the size and to make the diagnosis, but it's not enough to tell you to plan for surgery, because it will not be able to delineate the size, which can be done by CT. So that's why it's not sufficient enough to make plan. So that option C is correct. Option D says, although magnetic resonance angiography can define the size, it cannot the proximal extent of the disease. That one is also a false statement. It can get the size and the extent of it from CT angio. So the correct answer to option 227 is C.
You can go on. Okay. Sister, you can go on.
Okay. 228. Can you still hear me?
Yes, I can hear you, sister. We can hear you.
Which of the following statement regarding the use of platelet glycoprotein 2B3A inhibitor in percutaneous coronary intervention procedure is not correct? Okay. Actually, the glycoprotein 2B3A inhibitor has actually been studied and can be used in, and the study showed that for STEMI.
Hello, Dr. Hodge.
Okay, you're not hearing me.
We can hear you now.
Okay. You said that when it's used, it actually reduces the rate of death and significantly MI and the need for urgent revascularization over 30 days follow-up. So actually, the benefit is usually for those one with acute coronary syndrome. The actual effect of it takes effect within 48 hours. Unlike the clopidogrel that is within 24 hours, but this one within 48 hours, the reduction effect is noticed. It's actually the only disadvantage in glycoprotein 2B3A has is that it has increased risk of bleeding. But as for the benefits, there's beneficial effect of it, but there's increased risk of bleeding. So they were looking for the actual option, the correct one. It said that glycoprotein 2A2B inhibitor, that's A, decreases the need for urgent revascularization over 30 days. That's a true statement based on the study done. It reduces the MI and the death, even the risk of stroke and urgent need for revascularization within 30 days. So it can actually buy time while they are preparing patients for it. Okay. Option B says they decreases the rate of subsequent myocardial infarction. That one is also a true statement. It also, like we said, that it decreases the rate of MI, recurrent MI, death, and stroke. The option B is true. Option C said that the major reduction of clinical events of glycoprotein 2B, 3A inhibitor occurs within 48 hours. That's also a true statement. We say that its effects takes within you notice it within 48 hours. That's a true statement too. Option D said that for patients with acute non-SC segment elevation MI, routine early administration of glycoprotein 2A, 2B inhibitors at initial encounter improves 30 days mortality rate without significantly increases the risk of bleeding. That's what it actually increases the outcome, but has a very significant risk of bleeding. That's what makes that statement false, because they say that it does that without significant risk of bleeding. So the first option there is option D. Hello?
Sister, I can go on.
Okay, 229 says, which of the following statements regarding Prinzmetal angina is false? Like, we know that Prinzmetal angina is caused by transient coronary artery vasospasm. So it said that most people with Prinzmetal angina, when you do an angiograph, you might not see a significant plaque in intravascular or ultrasound study nearly at all the sites of the underlying atherosclerosis. You might not see it, but actually there's always an underlying atherosclerosis. Now, the said question says, the majority of coronary sites that manifest focal, the majority of coronary sites that manifest focal vasospasm have evidence of underlying atherosclerosis. No, when you do the coronary angio, most times you don't see any evidence of coronary, any plaque. So that statement is a false statement. You don't see any plaque when you do coronary angio. B, it can precipitate administration. It can be precipitated by administration of serotonin reuptake inhibitor. Sorry, I don't know whether you're getting what I'm saying.
They are following up with you. You can continue.
We are looking for the false statement. They said that there's no first of question A said that majority of sites that manifest focal vasospasm have evidence of underlying atherosclerosis. Okay, they have evidence of underlying atherosclerosis, but when you do angio, you will not see a plaque. Now, they said that both nitrate and calcium channel blocker have been shown to be effective in treatment of Prinzmetal angina. However, provocative tests with acetylcholine is only indicated when Prinzmetal angina is suspected and there's no evidence of SC segment elevation on ECG. That's when you do the provocative test. It has also been shown that coronary spasm have been observed after administration of an ergot, 5-fluorouracil, cyclophosphamide, and selective serotonin reuptake inhibitors. So they said that, okay, option B said that it can be precipitated by administration of serotonin reuptake inhibitor. That's a true statement, because we say that both selective serotonin reuptake inhibitors, ergots, 5-fluorouracil, and cyclophosphamide can precipitate Prinzmetal angina. Option C, calcium channel blockers and nitrate are used in treatment and prevention of attack of affected patients. That's also a true statement. Option D says Provocative testing is indicated in patients with non-obstructive lesion on coronary angiography, a clinical picture consistent with vasospasm and a documented SC segment elevation on electrocardiogram. Okay, now that one is the first statement. Remember that we said that you can only do provocative tests when you suspect angina, you suspect prismetal angina, but there's no evidence of SC segment elevation on ECG. So that makes that statement false. Patients with isolated prismetal angina have a low rate of sudden cardiac death. They said that for everything that prismetal angina is relatively benign, it's associated with low risk of sudden cardiac death. So the answer E is also a true statement. The false one there is option E. You don't do provocative tests except when you suspect it and there's no ST segment elevation on ECG. Contributions, please.
Sister, you can go on. You've done a great job.
Okay. 230 said, okay, what statement about the condition in figure 2.7 is not correct? So figure 2.7 actually shows an arterial emboli. It usually arises from atherosclerotic plaque of the abdominal of the aorta. A majority of them arises from the trunk leading to the channel. So it's actually, it can be called a cholesterol emboli. Normally, it occurs usually following manipulation of the aneurysm. So when you manipulate it, you can now lead to emboli. It can also be, it can be found in both limbs. However, it's usually found on lower limbs. And the clinical feature is that that's the injury you see there. There's evidence of if you look now, you can see the lace-like appearance. There's evidence of rhabdoid reticularis. They can occur with purpura. They usually have a lower abdominal pain. You can also have a positive visualization of the cholesterol plaque in the retinal arteries. One thing we should know that CT scan, CT angio, MRI may demonstrate the slope of atheroma. However, when you do a cholesterol biopsy, cholesterol crystal can only be seen on the skin or when you do muscle biopsy. But when you do the CT angio MRI, you see the sloughs on the vessels, the atheromatous plaques. But the other one, the cholesterol crystal, is usually seen on skin or muscle biopsy. Can we answer the question now? Said the most common cause is surgical manipulation of the atherosclerotic aorta. So when you that's the commonest cause of it. When you do the atherosclerotic manipulation of the aorta, maybe you want to do stents, or so that can dislodge it. Before you do it, you have to weigh the options and be sure whether you are going to put a filter and prevent it from embolizing, or you start the patient, first of all, you might start the patient on therapy like antiplatelets, anticoagulants. These ones can be done to prevent it from occurring because, however, when it occurs, it's actually difficult to manage. Management is usually conservative. Option B says that cardiac catheterization may lead to this condition. That's actually a true statement because that's the manipulation that can be done that will lead to atherosclerotic emboli. Angiography is a definitive test for the diagnosis. Remember, we are looking for the false one. The definitive diagnosis is not angiography. The definitive treatment is actually this muscle or skin biopsy, because that's where you are going to see the cholesterol crystals. But the angiography can show you the atheroma, but when you see the crystals, it's when you do the biopsy. Stigmata of this disorder may be visualized directly on direct inspection of the retinal artery. Yes, remember that we said that when the proximal aorta is involved, you can visualize it in the retinal artery. Levido reticularis is a recognized manifestation. Remember, we said the manifestation, it can have levido reticularis, you can have purpura, a chemotic lesion of the lower limb. You can also have abdominal pain, and the disorder, it may affect both limbs. So that's the option to that one. The first one is option C, is biopsy. That is definitive treatment or a definitive diagnostic test. Questions, contributions, please. Hello, can you still hear me?
Dr. Allison, she's done. Dr. Allison, she's done.
Yes, thank you. Thank you, Dr. Hodgie. We are grateful for your efforts. Thanks so much. At least we are glad you are able to take this despite all the challenges we went through the previous time. The time now is, this is 11:21. Okay. Dr. Adeyanju.
Yes, please.
Yes, I think we can round off for this night.
Yes, thank you for helping us to anchor. And thank you to everyone for their time. I appreciate everyone. We are really pushing hard, and by tomorrow we should be able to finish the second part of Braunwald and move on to the third part. So maybe between tonight and tomorrow morning, we will see the next distribution for the next presenters. Thank you very much. Thank you, Dr. Molade. Chief Okopi, Chief Kweki.
Yeah, Dr. Kweki had said he's recording, but he's not fully here. He has to prepare for something, I don't know. But he's helping us to record. Okay, Dr. Kopi is here. Okay.
Thank you so much, Dr. Allison and Dr. Adeyanju. Very excellent presentations today and great contributions. Oh, let's keep hitting the ground running. We're doing fine. Thank you. So we'll see you tomorrow again, right? So Adeyanju, well done.
Thank you so much, Chief. Thank you, everyone. See every one of us tomorrow. Good night, everyone. Dr. Miriam, thank you. We are happy that you are able to overcome this network challenge. Very happy.
Village people are not, they are not
They're not up today, right?
Yeah.